Right. Hello again. Welcome, everyone. Welcome to the Public Health Implications of the U.S. Pointer Study webinar. My name is Shelby Roberts. I am the Senior Director of Public Health at the Alzheimer's Association, and as part of that role, I lead the BOLD Public Health Center of Excellence on Dementia Risk Reduction. We're happy to welcome you with us here today. And go to the next slide. So this webinar, as I just mentioned, is hosted by the Center of Excellence on Dementia Risk Reduction, and this project, the Center of Excellence, is funded by the CDC. So I'm going to go over a few logistics and things before I turn over to our speakers, so that as I do that, please let us know in the chat where you're joining from, and as we start to learn a lot about the modifiable risk factors for dementia today, wanted to know what is something you are thinking about that you believe you could change in your behavior to improve your brain health personally or in your community. All right, so just a little housekeeping for us. We will be sending out the recording to all registrants, and it will also be available on the association's YouTube page, so there'll be plenty of ways to share after the webinar. If you would like closed captioning, that's available on the toolbar at the bottom. Also on the toolbar, you will see a Q&A function. Please type any questions you have for our speakers in that area, and they will be able to answer after their presentation, and we'll also have some time for Q&A. And then finally, everyone who registered will get additional information to any resources and links that we talk about today, as well as the recording in a summary email. All right, so let's go into our agenda for the day. I'm going to go over our learning objectives and introduce you quickly to our presenters. Then we're going to have 3 wonderful presentations and some time for question and answers at the end. So our learning objectives today, we're going to hear about 2 exciting projects. The first one is going to be about the U.S. Pointer Study, which you may have heard a little bit about over the last few weeks as these results have just been released. Then we're going to hear more about the Center of Excellence project to summarize the modifiable risk factor evidence into nice science summaries for you all to be able to use in your work. And then we'll also hear about what all of this evidence means for public health as we think about public health's role in dementia risk reduction. So before I turn it over to our speakers, I have one more job, and my most important job of today is to say a gigantic thank you to our team who has been working to get these risk factor summaries finished and updated and up on the website for you all to be able to use. This has been over a year-long project working with our partners at Wake Forest School of Medicine, and that team was led by Dr. Kate Callahan, who you see here on the slide. I want to give a gigantic thank you to her as well as her team and the 15 subject matter experts who helped us with all of the information you'll see in those summaries. And then go to the next slide, also thanking our association team, which was led by Mikkel Lewis, who's the Associate Director for the Center of Excellence, our amazing MARCOM team, as well as Catherine Stewart and Caitlin Kearney, and then other members of our public health team, Matthew Baumgart, Kat Colcom, and Heather Snyder, who helped us with the review, and all of the other people who helped click the links and make sure everything was looking great for you all to be able to use starting today. So thank you to all of those people, and we look forward to hearing how you are going to use all of this information to improve brain health in your communities. So now I'm pleased to introduce to you all our speakers for today. We have Dr. Heather Snyder, who is the Senior Vice President of Medical and Scientific Relations at the Alzheimer's Association, Dr. Jeff Williamson, who's the Chief Section on Gerontology and Geriatric Medicine at Wake Forest School of Medicine, and Matthew Baumgart, who is the Senior Vice President of Health Policy at the Alzheimer's Association. So right now, I'll turn it over to Dr. Snyder.
Thank you so much, Shelby, and thank you to all of you for joining today for this discussion and this overview of all of these different resources and tools as we think about brain health and as we really translate US Pointer into what it means in the community. And so it's really my pleasure to present with you the study results that were presented, and that's really the details behind the news that you may have seen in recent weeks and months on behalf of the leadership team and the entire study team of US Pointer. So when we think about US Pointer and we think about what we were trying to learn and what we were trying to understand about US Pointer, we were really thinking about, well, the growing challenge in the United States. The numbers of individuals that are living with dementia are on the rise. We continue to see this year over year across the board. When we look at the data and the science and what the science tells us, we know that there are certain behaviors or certain lifestyle factors such as poor nutrition or lack of physical activity or lack of the ability to engage in physical activity related to the community or the environment that are also linked to higher risk of cognitive decline. Early findings suggest that when individuals engage in behaviors that address those lifestyle factors, that they have a benefit on their overall brain health. And in fact, there was some work that suggested that there was synergy between these activities when done together. And so this allowed us to think about, well, when we combine multiple factors, what does that mean? And what are the outcomes that we see related to brain health? There was a study that presented in 2014 and published its findings in 2015 called FINGER, or the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. And what FINGER showed is that in individuals in Finland, so a relatively homogeneous group, when they looked at usual care compared to a behavioral intervention that combined nutritional guidance, physical exercise, cognitive engagement, and then medical monitoring, that they saw a benefit on cognition in over 2 years in an at-risk population. Now, Finland has some of the best access to healthcare and some of the strongest education, but also is relatively homogeneous in terms of its population. So it was unclear whether this would translate to an environment like the United States and across the United States communities. And this is why the Alzheimer's Association asked this question. Can we think about lifestyle strategies around brain health in older adults that are at risk, and particularly in the United States, and thinking about that intervention where people are living, eating, working, and receiving care in many different ways. And that's what we set out to ask and answer, to understand whether lifestyle interventions can protect brain health and reduce the risk of dementia in a large, diverse population that really represents our communities of older adults in the United States. And whether when you have varying levels of structure and support, do you have a different outcome on the impact on cognition? So with that, we set forth with 5 communities across the country: New England, Rhode Island, the Western Carolina and North Carolina, the Houston area, the Chicagoland area, which is really reflective of the greater Chicago area, and Northern California, specifically in the Sacramento area, and launched this study to recruit over 2,000 individuals. And those individuals were aged 60 to 79. They were individuals that did not regularly exercise, that had suboptimal diet, and we used the MIND diet, which I'll talk about in greater detail in a moment. We also looked for individuals to have 2 or more of the following: be over the age of 70, self-identify as African American, Black, or Native American from their race or of Latino and Hispanic ethnicity. They could have a family history of memory impairment, and also cardiovascular health risk, and that was looked at in a number of different ways. Now, we ultimately enrolled over 2,100 individuals from the U.S. population, and the age is looking at the age range across from 60 to 79. Over 78% of our individuals had a family history of memory loss across the board. When we looked at the population, around 68% were from white or European American, identified as white or European American, and then we had representation from the Asian or Asian American populations, Hispanic, Latino, or Spanish, individuals that identified as multiple races, or individuals that identified as Black, African, or African Americans. And so we looked at really trying to ensure that we were representative of the communities that we were recruiting in, and we can come back to this in a bit of time. We had 68% female and 31% male. And then we tested two different interventions, the self-guided and the structured. And while both groups received the same information regarding healthy lifestyle education, the differences were in the accountability and the structure, as well as the individual goal setting that individuals had to engage in. So individuals in the self-guided had 6 facilitated team meetings over the 2 years, while individuals in the structured had 38 facilitated team meetings in that same time period. And then you can see the differences between the interventions reflected here. So when we look at what this journey has meant to our participants, throughout the study, we collected feedback across the way, feedback from all of the individuals in terms of the impact of being part of research and part of this particular trial. And this was reflective in both this was reflective of feedback from participants in both intervention groups across the board in terms of that the program transformed their attitudes and behaviors towards thinking about brain health, doing physical exercise for the first time in years, becoming aware of how important it is to practice balance and stay flexible, and so much more. This is just a snapshot of that kind of feedback. When we look at the outcome, the primary outcome, our ask was around the impact on cognition and cognitive function. Individuals enrolled in the trial, it was over a 2-year intervention with baseline at year 1 all the way through the 2-year mark. And at every 6 months, individuals in the study came in for an assessment where we evaluated memory and other thinking tests in that period of time. So what did we find? So in the self-guided group, this was the intervention that met over the 6 times over a period of year. We did see that there was some improvement. Cognitive function is represented as a single line during the trial, which because we scored individuals at every study visit. And this was calculated as a variable among all of those cognitive tests taken together. And this was the average score across that. When we looked at the cognitive change, this is actually represented as a Z-score, so that every individual and participant is then statistically put to 0 as the starting point. And this allows us to do this type of model and this type of assessment. When we look at the structured group, which you see in the dark purple line here, we saw that both groups had the improvement over time. But the structured group had a significantly greater benefit on cognitive function during the 2 years or over the duration of the 2 years. And that this extra benefit was the same regardless of sex, regardless of age, race, or ethnicity, whether they had ApoE4 genotype, which is one of the risk genes associated with Alzheimer's disease, and regardless of their heart health at the start of the study. So what does this mean and how do we translate this? So we see the difference, we see that both groups improve, we see that there is a greater benefit for the structure group. What does this mean? When we look at conservative estimates of the model of this, it suggests that the structured group obtained scores that were similar to those of adults who were 1 to nearly 2 years younger, suggesting that we are having an impact on the cognitive aging clock by an extra 1 to 2 years compared to the self-guided intervention. Now, we didn't go into this study with a placebo or a group that received no intervention. And part of that was because, and I'm sure this is something that many of you can appreciate and understand, is that as the Alzheimer's Association, we believe, and that's really where the Bold Center comes into play, we believe that there's enough science that we should be talking about the benefits of these activities on brain health, even if we didn't have the exact information that we could translate to an individual. And so we gave everybody the same information, but then really evaluated whether the greater structure and accountability is beneficial and has a benefit on cognition. And this really suggests that that protection may benefit against cognitive decline in the future. Now, that's a question that we're going to continue to ask with a continued follow-on of these participants. We have an ongoing alumni extension where participants continue to come in on an annual basis for assessments, but they aren't still part of the intervention across the board. So how do we start to translate this? And a big part of that is around implementation. So the association commits $40 million to that next stage. Part of that is the continued analysis of data that we have. That includes biomarkers. We're just looking at the top line results of the outcome, which is the impact on cognition. But we also are then needing to follow and continue to follow those individuals in that alumni extension. We've worked with teams across the country to think about planning the implementation projects of the translation. Many of these include the U.S. pointer sites, and funding them to develop those plans going forward. And then coming soon, we'll have an open call program for implementation projects to help to move this forward. But of course, in all of this, there's nothing to report without our participants, which are incredible and have just made so much of an impact on our overall study as well as our study team. And so huge thank you to the incredible team that's behind all of this. And this is just a snapshot of some of those individuals. And I know we have time at the end for discussion, so we'll pass it back to, I think, Shelby, who will take us away. Shelby?
Thanks so much, Heather. It's really exciting to hear about this and to keep learning more. I unfortunately just heard that Dr. Williamson will not be able to join us. So Heather, we had a couple of questions that are very specific to your presentation. I thought it might be good if you wanted to give a few examples now, since we have a little bit of extra time. And both of them were around just asking you to say a little bit more about the intervention. One was specifically wondering what the aerobic activities were, and then we had another question just about the different components and what participants were doing in those components.
Yeah, can you see my screen again? I pulled the slide up again, just to talk through this. So this shows you, I saw the one that was specifically about the different components of the intervention. So this gives you the different components of the intervention. Now the aerobic, the physical exercise in many of the communities, we actually had memberships to a local Y for the individuals, although that wasn't true in all of the communities, as they weren't necessarily in that particular community. And so then we worked really to identify what were other partners or other local resources that could be part of the physical exercise. And then one of the things that was part of these team meetings was to set the goal setting and really set that standard for what and how individuals engaged in each of these components. So it included a lot of that individual goal setting based on where somebody's starting point was and then going forward. The specific, depending, and because there was so much variability within the communities and across the communities, it was then based on, well, what's that specific schedule, or what are those specific activities that could be possible? And then part of that team meeting, and this was particularly true in the Wake Forest community or the Western Carolina community, which we had enrolled participants during the pandemic. And as things started to open up, but not necessarily gyms or other places, they actually developed strategies thinking like going for walks or doing other types of activities that were outside or in a local park to develop to move that aspect of the intervention forward.
Great.
So I hope I answered those two questions. Yeah. Well,
and there's one more wanting to know if you can share any more about the cognitive training that folks did.
So we actually brought in, and it was we used a tool called Posit Science or Brain HQ. I think companies Posit Science and Brain HQ is the tool as part of this. That's the tool that's part of the active trial. For some of you that may know that, it's probably the longest running of the cognitive training types of studies that are out there. One of the things I didn't mention is that we actually powered this overall study to look at the individual contributions of the of each component of the intervention, so that we could look at that and really look at the individual aspects, whether it be physical exercise, cognitive training, the nutrition, the dietary guidance, the nutrition, and others, to try to understand what might be driving, if it was positive, if we saw benefit, what might be driving that. And that will be some of the follow-up assessment that we'll be doing.
Thanks so much.
I see a bunch of questions, Shelby.
Yeah,
I see that.
Yeah, we'll save them to the end. And Heather, you feel free to answer any that you want to type the answer to while Matthew's giving his presentation too. But we'll definitely have time at the end. So now Matthew Baumgart is going to join us and talk a lot more about what does this mean for us as public health professionals working in our communities right now. Matthew, I'll turn it over to you.
Thank you very much, Shelby. Hello, everybody. Very excited about the results of US Pointer and what it means for public health. And that's what I'm going to talk about. But if you go to the next slide, I like to start a lot of my presentations with just reminding folks of the urgency of promoting brain health. This is the projections of the number of Americans, older Americans living with Alzheimer's. So today there are 7.2 million, um, and that will increase to a projected 13.8 million in 2060. One of the key things here, so that in and of itself is a doubling between now and 2060 of the number of older adults with Alzheimer's. But I also like to point out that these projections are based on studies of recent cohorts of older Americans. And those cohorts lived through a period of time when they were younger and in middle age, where we had much lower rates of obesity and diabetes in the United States. In fact, recent cohorts of older Americans compared with people living today were going through a period when they were middle-aged where obesity was 3 times less, where diabetes was 8 times less. If obesity and diabetes are causal risk factors for dementia, and we don't know that from the science, but if they are, that means future older Americans, those who are will be older in 2050 and 2060, lived through a time and as a cohort had much higher rates of obesity and diabetes. And again, that may drive these numbers higher. Next slide. And so that urgency has really prompted some action, some major steps over the last several years. Going back to December of 2018, when Congress passed the Bold Infrastructure for Alzheimer's Act that really set as a goal to start building the public health infrastructure and the capacity of that infrastructure to deal and address Alzheimer's and dementia. As a result of that bold act, the Alzheimer's Association was named as the Public Health Center of Excellence on Dementia Risk Reduction. We are one of 3 centers of excellence funded by the CDC. And then in December of 2021, the National Alzheimer's Plan added a 6th goal that's focused on addressing risk factors for dementia. So, as public health increasingly addresses Alzheimer's and dementia, what do the US Pointer results mean? What are the public health implications? So if we go to the next slide, I'll talk through some of my thoughts on what this means from a public health perspective. So first of all, and Heather referred to this in her presentation, we've known those sorts of behaviors that are risk and protective factors and the role they play in brain health. And we've known that. Heather and I wrote a journal article 10 years ago now. But what US Pointer shows is that an intervention addressing multiple risk factors works to improve cognition. So while we knew what was good for brain health, we now know that there's a way to improve cognition with a specific intervention at the individual level. We also know, which is important for public health, that all populations can benefit. Not only was the recruitment and the participation in US Pointer reflective of the communities where the trials were taking place, but we saw that there was equal benefit, and the benefit of cognition, the cognitive benefit of the intervention was across all populations. So at the end of the day, it underscores the message that you probably heard us talk about and say a lot. What's good for your heart is good for your brain. It also emphasizes the importance of a public health community-based strategy to address dementia risk. This was a successful intervention, but it was done in a clinical trial context. And This was a trial that was in the community a lot, the physical exercise, the nutrition, but it also had a health monitoring component. Um, and the health system is really not set up and has very limited capacity to run an intense behavioral intervention, especially one that is multi-pronged and multi-domained like US Pointer. So we need to make sure that that community element of US Pointer really becomes the focal point and the point of entry, and that points to this need for a public health community-based strategy. And it also strengthens the case that we need more money to address dementia risk as a public health priority. So feel free to use it to lobby your state legislators, for example, on what they can do and how they can fund and promote brain health. Next slide. So what comes next? Heather referred to some of the implementation work that the association is doing, and we really need now implementation studies to inform how to successfully deliver this specific intervention as a public health program in the community. What you can do now as public health officials, you can first spread the word about the US Pointer recipe. You see on the screen the recipe, and that infographic is available on our website. But spread the word about what can be done and the recipe that people can follow to help keep their brains healthier. And you can use the results of this finding in your own public health campaigns and education efforts as you're promoting brain health and healthy aging in your activities. You can use this information as part of that or to inform what you do in those campaigns. As for the Bold Center, over the next year, we're going to work on a couple of things to help you. One is on community clinical linkages. As I've noted, there are things in this intervention that were in the community, but there was also the health monitoring. And increasingly, the public health is playing a big role in drawing those linkages between the community and the clinic. And this intervention is exactly that. And so we'll be working on that over the next year. And then on intervention implementation, what can public health do to try to get either build or promote specific interventions or specific pointer-based interventions in their community? Next slide. So as I noted, before Pointer, we knew risk factors from a population epidemiological based evidence review about what those risk factors were that played a role in brain health. And this was what you see on the screen, the most recent review by the Alzheimer's Association of 18 risk and protective factors that are most often mentioned as risk factors for cognitive decline and dementia. And we reviewed the evidence, we reviewed the reviews. So a lot of people have done reviews, and we kind of took the reviews and said, what areas do the reviews agree on and what do they disagree on? And we categorize the evidence for both as it relates to cognitive decline and as it relates to dementia, either strong, moderate, lower, or unclear. And you can see our conclusions on the screen. The 10 things on the left are the 10 factors with the strongest evidence and form the basis of our 10 healthy habits for your brain campaign. Now, that's not to say that those things on the right are not risk factors. It's oftentimes that there just is not yet enough evidence that there's emerging issues, that understanding the relationship between dementia and the risk factor or between cognitive decline and the risk factor is still not clear. So that's not, so none of, it's not to say that these are not, but just that the evidence isn't quite there yet to make it to what we believe is a strong or moderate level of evidence. So the 10 things on the left are what we believe have the strongest evidence and are the healthy habits for your brain. And that brings us to what Shelby mentioned at the very beginning. If you go to the next slide, we are now releasing updated summaries on those risk factors. And you can go to alz.org/risk reduction and download and read the modifiable risk factor science summaries. There are 12 summaries that cover, I think, 14 different risk factors. All of the 10 that were on the previous screen that make up the 10 healthy habits that have the strongest evidence are covered in 8 of those risk factors, because we've combined diabetes and obesity into one, and education and cognitive engagement is combined into one. But all of the 10 healthy habits are covered. The summaries include a review of the current state of the evidence and the implications for public health, and the role social determinants of health plays either in the risk factor or in the ability to address the risk factor. I should say that the 10 things with the strongest evidence have not changed. These 10 things go back several years now. What we have done is updated the summaries. The previous summaries were done 4 years ago, and this gives us an opportunity. The science is constantly evolving and changing with new studies. This gives us a chance to provide you with the latest on the state of the science. Next slide. So what can you do beyond US Pointer and the couple of things I talked about in terms of promoting the Pointer recipe and using that to inform your programming? What else can you do? So you can promote 10 healthy habits to raise awareness of what people can do on their brain health. You can integrate brain health messages into existing campaigns. So if, for example, one of your priorities in your public health agency is to promote helmets, bicycle helmets, you can incorporate messages about how that's good for your brain health to protect your head. Or if promoting physical exercise is one of your main activities, you can work in messages about how exercise can not only help your heart, but can help your brain. We did not get a chance to hear today from Jeff Williamson about hypertension and the latest data on hypertension, the latest studies on hypertension, but we do have a brief that's available on our website that's specifically on hypertension and how to implement actions to prevent and control it. And then we have toolkits on these other 2 items. One is on community convenings. You can use our toolkit to host a community convening, utilize the public health role as convener to bring diverse multi-sector stakeholders together around a table to build this larger effort in your community to address brain health. What can each individual stakeholder, each sector do individually, but what can you all do collectively to promote brain health? And public health has a big role in bringing those people and convening the community. We also have a toolkit on social determinants of health on how you can identify the main social determinants of health or the most prevalent social determinants of health in your community, and then address those dementia-related social determinants of health. As I said, all of this is available on our website, alz.org/risk reduction. You can also email us at centerofexcellence@alz.org and do a quick QR code on the left. If you're not already signed up for our public health e-news, please do so. It provides the latest on a monthly basis across the spectrum, not just on brain health, but also on early detection and diagnosis, tertiary prevention, quality care, dementia caregivers, and it provides updates on new studies, on new resources that are available for public health. And so really encourage you, if you're not already subscribing, to use the QR code and subscribe today. And with that, I will turn it back to Shelby.
Thank you, Matthew. Before we get going on Q&A, I had just two comments after listening to those great presentations. The first is, as Matthew mentioned, all of this is available on our website. We have updated the website to include all of these new summaries, and I believe Kat has put that in the chat, and we'll probably put it in the chat again. And then additionally, we, right below the summaries, link to the two journal articles about the US pointer study. So for many of you asking about more details on the methodology and other specific things related to the US pointer study, you can find those two journal articles linked on our risk reduction webpage. And then the second thing I wanted to mention, because the majority of you joining the call today are public health professionals and many of you work for health departments, one of the main goals of the Center of Excellence is for us to translate evidence and package it in a way that is useful for you. That is really the purpose of these science summaries. When you open them up, you will see a short but detailed section outlining the science. As Matthew mentioned, there's been a public health implications section as well as a social determinants of health section for each of them. We hope this is helpful to you as you're writing grant applications or as you're building a justification to run different programs that you're doing in your community. And always reach out to us if you find yourself needing additional information or have any questions about them. We are here to help. So with that, I'll invite Matthew and Heather to come back on the screen. We've had a lot of questions coming in, and thank you so much to Heather for answering many of them. Heather, before I start to dive in, were there any that you answered typing that you think the rest of the audience might be interested in?
Two biggest. A lot of them were about specifics of the intervention or specifics on the population. And I didn't spend a ton of time. I just touched on both of those. And so I know, Shelby, you mentioned that you're going to be sharing the two links of the two papers, two of the outcome papers, but maybe we can also put in the chat both the methods paper and then also the baseline characteristics paper as well, and share those with everybody because there seems to be a lot of questions on that. The other thing is one of the questions I saw, and my guess is this is one others are thinking, is what's the timeline of the implementation RFA? And so we are working on the initial kind of planning grants that we talked a little bit about right now. And then the open call RFA, we're expecting that to be in around the next 9 months or so. But we'll certainly work with Shelby and team to disseminate and distribute information broadly and widely to a number of different audiences and potential collaborators on those applications and what that could look like.
And Shelby, could I just jump in here on the implementation study? Sorry, Heather. As Heather mentioned, we are funding some planning grants on implementation studies. To mention the pointer sites themselves are being used, but we also have two state public health agencies that are receiving or are participating in this planning process, and we'll be planning an implementation study because we wanted to, as Heather noted, have different approaches to find out, because ultimately we're trying to find out how do we get this into communities successfully? What's the most successful strategies and tactics to get this intervention in the community? And so public health is obviously one of those. And so we have a couple of public health agencies that are participating in that.
Great. So Matthew, you started to go into what was going to be my first question. I just scanning through I think the favorite thing I read was 38 sessions sounds like a lot. Is this replicable? And of course that is what we're going to be testing as we test this more. But Heather, I thought it would be good if you could speak a little bit to the attrition in the study. You know, did people stick around for all those sessions? And then Matthew, if you want to add in about the different elements you're interested in as we start to test this more. Oh, Heather, you're on mute.
Sorry, with the little orange thing next to my name, I couldn't see it. Apologies about that. We actually had a much lower attrition than we had estimated in our statistical plan for the study. And in fact, over 90% of the participants stayed in the trial throughout the 2 years. The reasons that most individuals There were a number of different reasons. There was not any specific aspect or specific kind of trend in reasons for individuals. Some of it was during the pandemic, their children moved. They wanted to be closer. They were no longer in a site where there was US pointer. We didn't allow for that to continue. There were other health issues that came up that they needed to then manage and deal with. So there were a number of different things that were that accounted for individuals who discontinued in the overall study, but nothing that was no specific trend across the board.
Yeah, Shelby, from my standpoint, this 38 meetings over 2 years is a really good example of why we need some implementation studies, because the real world isn't like a clinical trial. And another one is for the purposes of measuring the cognition. They went in for the health monitoring and measurement, I think, twice a year, which is not a typical practice. We don't usually go in to see the doctor and get um, uh, get checked every 6 months. So the key thing about implementation science, or one of the key things about studies to bring it to the community, is what elements do you need to remain faithful to, and which do you not need to be faithful to, strictly speaking, and still have outcomes and success that you want. So those are two examples. Those are probably the two best examples in my view, because physical activity and nutrition and the cognitive engagement were key elements, and then the health monitoring. But can you do it once a year? Can you have team meetings a few times a year rather than 38, and still maintain the outcomes that you see in the clinical trial? And that's what the implementation studies are for. How do we work this in the real world?
Kind of building on that a little bit, there are questions across the board about different age groups. So Heather, wanted to see if you could speak a little bit to why you all chose the age group that you did. And then Matthew, there's a question in there I think you would love, which is, do we want public schools to do this type of an intervention? Or what other age groups are we thinking of when we think about this work expanding?
Yeah, so as I started, we looked at the finger trial, and the finger trial had been 60 to 77, and we were really looking at, could we replicate that and their findings in a US population? We did go 60 to 79 because between when finger had launched and when the US and when US pointer launched, there was an increase in longevity, expected longevity, and so we took that into account, and so did 60 to 79. But maybe just one of the things I'll editorialize here is one of and my guess is this is part of the question, is, well, what's the difference between 59 and 60 in terms of enrolling? Well, it was the cutoff criteria for the study overall, but in terms of thinking about the public health interventions and the implementation, probably not much, and maybe not much difference between 55 and 60, particularly if but again, this was an at-risk population, and that's what we can answer. That's what we can look at the intervention and address that as a whole, this intervention impacted an at-risk population based on all of the criteria that we talked a little bit about. The specific components of the intervention, those still remain to be seen. That's the data we have at this point in time. Lots more to do with this information, lots more to do with this data.
So in terms of schools, Shelby, yes, this is I really think schools should be talking about brain health, and they talk about heart health. They teach kids about heart health. For those of you who are parents, you probably had your kids come home and tell you that something you're doing is not good for your heart health, as your kids love to chastise parents. But that's ingrained in kids from an early age, and in the schools, ways to take care of your heart and the importance of heart health. And I would love to see schools do that same with brain health. A lot of the things to keep your heart healthy are things to keep your brain healthy. And yes, I think educating kids about that is important.
Yeah, and not to get on my public health soapbox, but that's the beautiful thing about public health when we forget where we learn it, or it's just really becomes ingrained in the culture. Like, how did you learn not to eat food that had been sitting out at the family reunion all day, right? Like, that's public health food safety, but it's also something you learn not to eat those mayonnaise-based casseroles that have been sitting out all different kinds of ways, whether you knew it was a public health message or not.
Yes, and the other thing,
Okay.
Shelby, I saw somebody mention in the chat the Scotland brain health program, and I was speaking with one of the people a couple years ago who helped design that program, and he actually said one of the things about getting into the schools is you may forget it for a while, but then when you're 50 years old and people start talking to you about, oh, your brain and you're getting you're starting to get up there in years, the recall comes back. Oh my gosh, I remember that in school. I remember learning about brain health in school, and it triggers things at various points in your life. So um, more for the kids.
All right, so my last question is a hard one. I'll save the hard one for last, but it's about kind of how we came up with these lists. So we know there's lots of lists, lots of risk factors. Matthew, wanted to see if you could talk a little bit about how we came up with the list we did for the risk factors to look into at the center, and then Heather, for you to talk about how you all picked the different components for the pointer study.
Yeah, so there was a journal article published a couple of years ago where the researchers looked at the literature published in scientific journals on risk factors for dementia, and they found there were published studies on 364 different modifiable risk factors for dementia. Now, some of those were one-off studies. Some of them were things that turned out not or the study results turned out to be negative. But that's the panoply of things that have been studied, and we can't look at 364 things. So the 18 things that we looked at were really the 18 things that are most often mentioned by folks as being risk factors. And there have been multiple reviews by very esteemed panels like the Lancet Commission. There was the Blackfriars Consensus in England. That's been more than a decade ago now. And there have been other reviews conducted of the literature. And what we did is really what are the ones that are in these reviews mentioned most often as risk factors for cognitive decline and dementia. And that's led us to the 18 that we then looked at and categorized based on the state of the evidence. Again, just as I said on my slide, those ones that were on the right may be risk factors for cognitive decline and dementia. And there may be things that are not on that list that as the science emerges, I think, when we did this 10 years ago, I don't know that hearing loss was among the listed things that we looked at. That's really this emerging area. Air pollution is really emerging and getting more and more studies done on it. So things will change. The science is always evolving, and things that are not on the list may turn out to someday have strong evidence, but the 18 that we looked at are the ones that are most often mentioned.
And then in terms of the specific aspects of the intervention and why we picked, again, that comes back to, we really looked at when Finger had launched, what Finger found, its outcomes, and that impact, and we were asking the question of could we translate that to a U.S. population. So we leveraged updates in the science since then. So for instance, we didn't have the same dietary guidance, we didn't have the same exercise regimen or prescription, so to speak, because we took what we had gained in our scientific knowledge and then translated it into that 4-domain intervention component that was part of US Pointer. but maybe I could add just one other part, Shelby, just as a piece. And so, you know, Matthew talked about all of these other components. So thinking about sleep, thinking about some of these other aspects within the aspects of what may be modifiable risk factors and impact risk and benefit brain health. And so as part of US Pointer, we asked some of those questions as well in terms of the impact of the intervention on sleep, the impact of the intervention on some of the vascular related measures that are kind of beyond looking specifically at hypertension and looking at the impact on the underlying biology that may be related to Alzheimer's or other neurodegenerative diseases. Now, we don't have all of that data yet. We're still analyzing it based on the outcome of the top line results and going and taking that forward. But those are some of the questions and some of the data that we do have from ancillary studies that had been funded by the National Institute on Aging. And so really, that's going to be more coming soon. This is the top line and the top line only. We had the last participant in May. Between May and now, we've done the analysis, submitted, published the manuscript, and then presented the findings. And we know we have a lot of work to do to really analyze and get some of this additional data so that we can think about some of those translation. I know there's a lot of questions on other aspects of did we think about this? Did we consider this? Did we look at this? And so much of that is in the data, but it wasn't part of the primary outcome, which is what what I talked more about.
Yeah. And that was going to be my closing remark, is that this is just the beginning. This is the very beginning of many conversations that we'll all be having, but really excited to have this additional evidence base that has been through many studies that you'll see summarized in the summaries, and then of course through the US Pointer study as well. So it's giving us so much more to propel this work forward. I'm again so sorry that Dr. Williamson was not able to join us, but that gives everyone now a to-do on the very first science summary for you to read, because he wrote the science summary on hypertension. So you can read all about what he would have told you today in that science summary. And I hope that you all go do that and go check out those updates on the website. I'll add that they are, we're printing them in a nice cardstock. So if you find yourself wanting to take these to different conferences or to give to other community leaders, let us know. We're happy to send them to you so you have those nice printed copies to go along with all of the information on the website. Thanks so much to our speakers, and thank you to all of the people who were involved in making the US Pointer study a success and getting the science summary update finished. We are grateful for all of you for joining us today and look forward to working with you in the future.